start the session. Thank you all for coming. This is a Minnesota special event webinar for what is a Minnesota POLST and who needs one. My name is Rebecca Thoman, and I coordinate the Doctors for Dignity campaign for Compassion and Choices, and I work here in Minnesota. Next slide. Compassion and Choices is a national nonprofit, and our mission is to improve care, expand choice, and empower people at the end of life. Next slide. Our special guest today is my good friend and our co-medical director for Compassion and Choices, Dr. Susan Wilhoit. Susan is board certified in hospice and palliative medicine, comes from Denver, and I'm going to hand it over to her to walk you through what is a POLST and who needs one.
Thank you, Rebecca, for that introduction. And yes, thank all of you for coming today and taking your time to visit with us and learn about the POLST, specifically as it relates to Minnesota. I'm hoping today that we can really get a better understanding of what we mean when we broadly talk about an advance directive. And then more deeply, I want to talk about the POLST specifically and why a POLST and an advance directive are two different forms, but really delve into what the POLST is, the three main components of it, and help everyone on this webinar understand who should have one versus maybe someone who just maybe needs an advance directive. And ultimately, our goal is always to help all individuals really feel empowered to articulate their wishes, explore their wishes with their loved ones, with their medical team, and really be able to express their end-of-life care. So let's just start at the beginning with what is advanced care planning. I think a lot of people are talking about that these days, and it's a term that we hear thrown around. But when I talk to people about advanced care planning, I think of it as a process. So this is not just a decision that is made, but rather it is a whole process that is really meant to include your medical understanding of your medical situation, but also your own goals of care, who you are as a person. I think that advanced care planning, when it's done well, really does a great job of understanding an individual for who they are, but also in the context of the complexities that they're facing. As important as those two things are, just as important is the formal documentation. So we've got to write this stuff down, and we've got to do it in a way that's actually meaningful and can be conveyed to the right people in the emergency situations that we may need our voices heard. So with advanced care planning, that's just kind of our big umbrella title, there are two different main documents, particularly in Minnesota specifically. One is the advance directive and one is the POLST. So the advance directive is a formal legal document versus the POLST is a medical order. The advance directive is going to have two parts. One is what we think of as a guide, providing information, discussing what the person would or would not want. Whereas the other aspect of it is where the patient or the individual who's filling out their advance directive can actually name who they would choose as their healthcare surrogate. In Minnesota, we call that, in Minnesota, it's called the healthcare agent. Other places you'll hear healthcare power of attorney or medical durable power of attorney, but specifically in Minnesota, the advance directive is going to include both the living will and also the designation of a healthcare agent. Whereas the POLST, going back to that, it is a medical order. So specifically that acronym stands for the Provider Orders for Life-Sustaining Treatment. And the POLST is a document that goes wherever you go. So it can be followed from facility to facility, if you're in one hospital and maybe transferred to a nursing facility, or you go home. And the good news about the POLST is it can go wherever you go. So again, I'm going to throw out different terms because I think that if you're ever talking to people just in Minnesota, you can really just, I think, rely on the healthcare directive, the healthcare agent, and the POLST form. But if you're out and about and you're hearing things in more national media or national outlets, I just wanted you all to see these names so that everyone would feel that they have a pretty good sense of what we're talking about when we're talking about each of these documents. So again, the living will, healthcare agent, or proxy, surrogate, all of those are going to be captured under Minnesota's healthcare directive versus the POLST, which in some states can be called the POST, the MOST, or the MOLST, all of which share the same spirit of a provider order, a medical order that's intended to be a direct articulation of the person's wishes written as a medical order. So I want to, before we delve deeply into the POLST, I do want to take some time to really understand and hash out Minnesota's advanced directive, again, called the healthcare directive. And again, this is a legal document, it has two parts. The first is where we are actually documenting the healthcare agent or the power of attorney for healthcare. The second part is going to be that living will aspect, where you're really trying to provide the care instructions that you would want, or maybe outlining the care you would or would not want, so that your healthcare agent can actually use the living will or use those instructions to help guide them as they are asked to make decisions for you if there is a time where you can't speak for yourself. I also want to pause, reflecting on the role of the healthcare agent for a moment. This really should be an individual who you truly trust to advocate for your voice, to really elevate, uplift, and speak on your behalf if there's ever a time where you are not able to. I encourage folks to really try to be intentional about choosing someone who they feel is not going to make the decisions that they want for you, or maybe that they want for themselves, but rather is going to give voice to you, so that if you can't use your voice, you can feel confident that this person is truly going to speak most highly and most accurately on your behalf. So moving on to the POLST, the provider's orders for life-sustaining treatment. It's quite a mouthful. Again, we call it a portable medical order, meaning that it actually goes with you. A lot of people that are not in medicine may not know that an order that's made in the hospital doesn't get carried over to the order that may be in a nursing home, or certainly not an order that you're going to get at home by any means. But the beauty of the POLST is it is a document that actually goes with you. So you could be out with friends out to dinner, and we'll talk about this later, but you'll have your POLST on you, your POLST will be with you. And if there is some sort of medical emergency, you could be at a restaurant, you could be at a hospital, you could be in a facility, and that the emergency medical folks that respond are going to be able to follow your POLST because it goes where you go and it's enacted in the jurisdiction or in the state where it was made. So in Minnesota, you can feel comfortable going throughout Minnesota, knowing that your POLST will still be able to be honored and upheld. And again, I think of this as the medical version, the medicalized version, medical order version of your voice, of your wishes, so that if there is a time, again, where you're not able to actually speak on your own behalf, then at least the emergency medicine folks are going to be able to know what to do, and they're going to be able to follow your wishes based on the signed order. And again, this is used across the healthcare system. Hospitals, long-term care facilities, nursing homes, all different types of medical professionals, and really most importantly, probably EMS. So first responders, paramedics, fire people, anyone that's really intended to be there for an acute medical emergency and need to know how to care for you. So this is an example of a POLST. It's actually a 2-page form, but for the sake of the presentation right now, I just wanted to show you this first page. And again, this is a way of communicating. If there's a time where you can't actually speak, the POLST is intended to speak for you. And I like it because for me as a physician, as a palliative medicine doctor, it's so important to me to be able to have conversations with individuals. Again, going back to one of our earlier slides, just because I want to know who this person is. What makes you tick? What are your values? Where do you find joy? What brings your life meaning? And understanding that in the context of your actual medical situation really helps us create that shared decision-making approach, so that when we sit down to have these conversations, we're not just checking a box, but we're really trying to be really thoughtful in how we consider each of these choices that you're faced within the context of you as a person, you as an individual. So that's another reason I like it, because it fosters that conversation. I will say I've had plenty of patients and met lots of individuals that unfortunately in their practices, their physicians or their doctor's offices have just maybe given this to them and say, here, fill this out, check these boxes, and bring it back to us whenever. And that's really not how this is not meant to do. So if that ever happens to you, I want to encourage you to say, whoa, please feel free to advocate for yourself and say, look, this looks like a pretty important document, and I feel that I really should have a conversation with you about these options that you're presenting me. I'd love to schedule a time to go through this with you, because you have every right, and it's intended to be a conversation. But of course, as we all know, in many things in life, not everything works out as it's intended. But I do want to just give you that little added oomph or fuel or encouragement to say, hey, we need to have a conversation about this, because I really do want to understand what these options are. And I want you to help me understand how they apply to me as a person. And that's completely fair. Again, we've talked about this. It's applicable throughout the healthcare world. I always like to point out to my own patients, actually, when I'm working with them on this, is that this is signed both by the patient or the surrogate and, the healthcare agent, if the person's not able to fill this out for themselves, and the physician or the licensed provider that's having the conversation with them. And the reason I think that's so important is because I think it kind of goes back to that idea of shared decision making. So you really are fostering that conversation, but also because it is a medical order, it is the physician or the PA or NP or whoever the licensed provider is, it's really their way of honoring your voice and reinforcing that this is your wishes, these are your wishes, this is your voice to the medical community, so to EMS, to first responders. So I think that's so important to know that really both entities, the patient, or like I said, the surrogate or healthcare agent, and the physician or the provider sign this. However, little caveat, as you see with the asterisks, in Minnesota specifically, in order for the POLST to be valid, you do not have to have the patient's or the surrogate's signature, which is different. I have seen that before until I was reviewing the Minnesota documents. In most places I've worked, I should say, in North Carolina and Colorado, we require both signatures of both parties. But again, I do think it speaks to the spirit of that shared decision making and the value of conversation. So again, we know now, I think people understand with advanced care planning, the big broad umbrella of the conversation, we have two main documents, two distinct documents, the advanced directive and the POLST. We know that the advanced directive is the legal document, the POLST is the medical order. The legal document of the advanced directive is going to define or identify or name the healthcare agent, just that surrogate, that person who you trust to be your voice and to uplift your wishes and make decisions for you based on your best interests. And they're going to make those decisions based on the information you provide in the advanced directive. That's really going to help inform them as they understand your values and your priorities, and it's going to help them make the best decisions for you. In contrast, that POLST, the medical order, is actually speaking directly to healthcare providers, emergency medicine folks, RNs, anyone in healthcare that is able to receive a physician's order, to make sure that the care they're providing is actually in aligned with your wishes, with what you want. So the legal document, because it's not a medical order, EMS, nurses, et cetera, cannot do anything with that. Versus the medical order of the POLST, absolutely. That's what its intention is. That's what it's here for. Who needs an advanced directive? Everybody, all of us. If you're 18 years and older, you should have an advanced directive, because you want people to understand what your values and priorities are, knowing that they change throughout our lives and throughout our own health journeys. But really, all of us, 18 years and older, deserve to have someone that we've chosen speak for us if there's ever a time when we can't speak for ourselves. However, the POLST is really intended for folks who are facing a serious illness or they're frail. And for any reason, some websites will tell us that if your physician thinks you may die in the next 12 to 24 months, you should have a POLST. I generally ask folks to consider this when they're seriously ill or facing some sort of significant frailty, because I am concerned that something could happen in an emergency situation, and I want to make sure that their voice is heard and that their wishes are upheld in those situations. I do want to say, while I'm on this slide, just tell you all a quick story, if that's all right. Working in the palliative care world, I'm not doing this currently, but I used to do a lot of consults in the intensive care unit in the hospital setting. And I can't tell you the amount of times that were devastating situations where it's, say, a loved one, the daughter, for example, is at the bedside and she's so clear that her mother had this advanced directive. She had a living will. She articulated all of the things she would and would not want. And she absolutely doesn't want any of this, meaning at this point, typically life support, mechanical ventilation, and hooked up to machines. And the daughter is just devastated because when the emergency would happen at home, for example, she showed the fire event, she showed EMS this is the advanced directive. This is what she wants. She doesn't want any of this. Stop, stop, stop. But because it's a legal document and it's not a medical order, EMS cannot honor that. And the amount of times I would see people in the ICU in similar situations where they're now hooked up to machines that they never wanted, despite having well-documented advanced directives. Unfortunately, the first responders have no way of honoring that because it's not a medical order. I also want to share, a good friend of mine is a professional firefighter, and the times where he has felt such angst because he knows that this person has a beautifully documented advanced directive and the power of attorney or healthcare agent is right there saying, look, no, stop, stop, stop. And he, as a firefighter, as a paramedic, feels profound angst because there's nothing he can do without the POLST, without the medical order actually directing his care. So that's why I really do want to encourage everybody who is seriously ill or frail to really consider advocating for a POLST conversation with their medical provider.
Quick question, Susan. I'm going to
yeah.
just jump in because it's a good
Yeah.
question. Should a person who wants full emergency care have a POLST?
Meaning full emergency care, meaning like full court press, do everything kind of thing?
Right. Yeah.
I would say if you are seriously ill and frail, it would be worth having a POLST in that situation. I think so, because, and here's my reasoning for that, is a lot of people, and I've been in situations like this actually as a provider, there is an assumption, oh, this person's seriously ill or frail, they probably don't want us to do much. Let's just tread lightly and see what happens. But if I always tell patients, if you have really clear goals in any direction, so it could be full court press, I want to do everything, or it could be no, comfort focus only, don't do all this to be. Either end of the spectrum, if you have very clear goals for yourself, I would still advocate for you to have the POLST, because it is truly the only way we have of offering a medical order to uphold your voice. I hope that answered that question.
Yes, thanks.
Okay, yes. So just running through a scenario, we're going to look at a motor vehicle accident that someone who's otherwise pretty healthy, 56 years old, is in a surprised car accident. So as per usual, 911 is called, 911 arrives, and first responders begin life-sustaining treatment. They're transported to the emergency room. That life-sustaining treatment continues. Meanwhile, someone's trying to locate the advanced directive. Now, healthcare agent, the doctors and the healthcare team are able to actually find the healthcare agent on the advanced directive. That's great. So then the healthcare agent is now able to make the decisions about the person's care. Of course, the agent is making those decisions guided by the directive, guided by the patient's actual information that the patient shared when they completed their advanced directive. So that's kind of a best case scenario. We find the healthcare agent, and the healthcare agent is able to make those decisions guided by the healthcare directive. Alternatively, though, and this often happens, unfortunately, either the healthcare agent is unavailable, or they're not able, the hospital team or the emergency folks are not able to find the healthcare directive, or it's inaccessible for some reason. And so in Minnesota specifically, the next of kin is going to be making your decisions. And I certainly know plenty of folks who would never want their next of kin making any decision or knowing anything about their care. And so again, I think the healthcare directive is a wonderful protection to make sure that when it comes down to it, if there's ever a time where you can't speak for yourself, you have people who you really trust, who really know you, and who you really feel comfortable are going to honor you. That's who you want to choose as your healthcare agent, because maybe you don't want your next of kin. Maybe you do. And of course, if they don't find your next of kin, or they don't find your healthcare directive, the default is going to be do everything, life-saving care, life-sustaining care. And so that's what we think about: full court press, life support, machines, ICU. And that is how we treat everyone right now in our healthcare system. And for some people, that is absolutely the right thing to do. And for some people, it's not. So I think that particularly for people who don't want that course, it would be reasonable for them to just actually focus on something like a POLST, feeling comfortable that as if someone who's seriously ill or very frail, or really maybe their doctors think that they're likely to die in the next 12 to 14 months, the POLST is really going to allow that individual, that person, to dictate the care they would or would not want. And it really makes sure both for the EMS folks and other medical providers that we are honoring this individual's wishes. So again, specific orders, we followed all of this before. We know that it could be available throughout the healthcare system. There are 4 main components for specific medical decisions that individuals need to decide, like decisions people need to make when they are considering their most. So if they're POLST, pardon me, I may say most every so often. Living in Colorado, practicing in Colorado, most is our POLST. So I apologize if I ever make that slip. So the first scenario, I tell people very bluntly, you have died. Your lungs are not breathing and your heart is not beating and you are dead. The second scenario is that your heart is beating and or your lungs are breathing, but we know that you're having pretty significant heart stress or respiratory or lung distress. And maybe we're concerned that your heart's not going to continue beating, or maybe your lungs are not going to continue breathing. So we know that it's a critical situation. So I think about that 1A, if we see heart not beating and lungs are not breathing, you've died, versus that 1B is you are critically injured, you are critically ill. The second section that we see here is on nutrition, meaning that when we ask questions about that, and that's particularly when individuals, for some reason, oftentimes related to a swallow dysfunction, are not able to maintain nutrition by mouth. So they're not able to take in adequate nutrition by eating food because for some reason it's unsafe. And the third aspect we'll get to in a little bit is when we have an infection that could be potentially life-altering or life-threatening. So let's see. With the part A, again, this is where I'm just very blunt with folks. You've died, your heart is not beating, and simultaneously your lungs are not breathing. No pulse, no breathing. So in this, we have 2 options. This is what we typically think of as cardiopulmonary resuscitation. So we're going to do everything we can to beat your heart. So we're going to actually do those compressions. It's going to mechanically, externally beat the heart so that the oxygen that's otherwise just sitting in your blood, not moving because your heart's not able to pump it, we are physically, mechanically pumping your heart for you. And with that, of course, we have to break ribs. It can be very physically violent. And it honestly, in order to be done well, it should be very forceful. And oftentimes ribs do break because we have to be so forceful, because we are trying to actually externally compress your heart in a forceful way to get that oxygen where it needs to go, most significantly at that time, the brain. And so with that, we have to provide those compressions. Meanwhile, we're also trying to get oxygen into your body by offering some external oxygen, airway support. So this is what we think about CPR. So people have 2 options. You can say, yes, attempt that, please attempt that. And I highlight here attempt because it's the attempt. And we used to just say, oh, we'll resuscitate you. And the reality is we may not, we'll be honest with you, we may not. So we're going to attempt that. Or you can say, and this is what my patients sometimes will tell me, look, if I'm dead, let me stay dead. Allow me to have a natural death. And I love that in the Minnesota document on the POLST, it actually says that specifically, allow natural death. A lot more states are actually offering that language now, because it's not, hey, just give up, let me go. It's allow my body to take its natural course, which is what's happened when you no longer have that heartbeat and the lungs are not breathing. So those are those 2 options. We see it often written as DNR or DNAR to emphasize that attempt. So I'm going to make sure I get good. So with part B, this is that part that really focuses on somebody who might be critically ill, meaning that your heart is beating with, and your lungs are breathing. And so we are concerned that there's something wrong with your heart and there's something wrong with your lungs, that something's going on, may not be life sustaining. So our options are threefold. You have 3 options. The first is full treatment. So this is what we think of as like being in the ICU, being on life support, using intubation. Intubation is where we put that tube into your mouth that we then have to go into your airway to directly provide oxygen into your body. And with that, that's what we have to put tape around your mouth. Oftentimes, whenever someone, most of the time, almost all of the time, when someone is intubated in that mechanical ventilation, we do have to sedate people because most people cannot tolerate having a giant tube in their mouth and taped down, among everything else that's going on. And so I do like people to know that full treatment does mean oftentimes sedation during that period so that you can actually tolerate the mechanical ventilation. Folks that undergo, so if you think about it as like full court breast, that's the intensive care unit, life support. The second option is selective treatment. And so this is for folks who say, look, yes, do everything you can that you think might be reversible, but I don't want to be intubated. I want to avoid the ICU. I don't want mechanical ventilation. There are other ways of receiving oxygen or airway support. Some of you might be familiar with the term CPAP or BiPAP. Those are what we consider less invasive ways of providing oxygen artificially to the body for people that aren't able to breathe well on their own. Those won't necessarily stick the tube into your mouth, but rather those are the masks that force the oxygen into your airway, but it's not going to be that tube. Some people tolerate those two much better. Some people still really struggle with both the CPAP and the BiPAP. With the selective treatment, you can go to the hospital, but ideally you want to avoid, the folks that choose selective treatment are saying, I want to avoid the ICU at all costs. And the third option is for comfort-focused treatment, saying, look, I understand that I'm in the final phase of my life. I do not want to pursue any aggressive treatment. I do not want to go to the hospital. I want you to do everything you can to focus on my comfort. So kind of recapping, full treatment, I think of it as do everything to keep my physical body alive. And I emphasize physical body alive because, again, most people have to be sedated when they're in this full treatment mode of care in order to tolerate the mechanical ventilation and the intubation. So I think that it's important for people to understand it's not that you quote do everything and you're active and interacting with your loved ones, but you're still sedated in the ICU on life support. With the selective treatment, you're saying, I do not want to be intubated. I don't want to be on breathing machines, the mechanical ventilation. Ideally, I want to avoid the ICU, but yes, transfer me to the hospital. I'm okay with that. And treat things that are reversible. Oftentimes in the Colorado MOST form, our version of the POLST, we have a section here where I can write additional orders and I'll talk with patients. And if it aligns with who they are and what they want, I will actually write, treat reversible conditions. If condition does not appear reversible, please discuss with loved ones and consider transition to comfort. So that way the person when I'm having the conversation with them, they don't feel that, oh shoot, I'm going to now have to be in the hospital forever and ever and ever. And worse things can possibly happen. They can actually say, look, if my medical team is pretty clear that this is not going to get better, it's okay to transition to comfort, which now leads me to the comfort care. So whereas the top full option is that, quote, do everything to keep my body alive, the bottom option, the comfort focus, is do everything to optimize my comfort. Do not prolong my suffering. In this setting, folks definitely avoid the ICU, and ideally, they avoid the hospital altogether. The best, and frankly, the only way I can think of to make this feasible for individuals is to have hospice care involved. Of course, hospice is a wonderful resource. And you can't just say, I want comfort care and therefore I want hospice, because there's certain criteria that you have to meet in order to be eligible for hospice, of course. But I would say that if someone truly is in the final phases of life, the last 6 months or less, that's the typical hospice benefit. And they're, what we would say probably terminally ill, and they truly just want to focus on comfort, having that hospice support is really the best way to avoid the ICU and avoid the hospital, because instead of calling 911 under comfort focused care with hospice, you call your hospice team, and they're going to be able to provide you the expert level symptom management in order to maximize your comfort. The third section is actually part E. So we did A, B, and we skipped over C and D, but now we're on to part E. And that's about the additional preferences that in Minnesota people can make, the different options you can have. So the first is about artificial nutrition. And so you can, for artificial nutrition, we basically, again, we talked about it a little before, someone's not able to maintain their body's nutritional requirements by eating, by taking food by mouth. And so we give them the option of doing a feeding tube. So you can say, yes, I do want a feeding tube, or no. Within yes, you're open to feeding tube or open to artificial nutrition, you can say you have two options again, short-term or long-term. My recommendation to most folks is that if this is something from which they are expected to recover, so maybe they've had some sort of stroke, maybe it's not a profoundly life-altering stroke, but they're expected to make some recovery, then a feeding tube, and their goals are interested in life prolongation and returning to closer to where they were before their event, then it'd be reasonable to consider a short-term feeding tube so that their body, the nutrition that their body needs to help heal, they can get through a short-term feeding tube or artificial nutrition. Versus a long-term feeding tube, that's going to be a more cumbersome process. It's surgically placed. And those I typically will say, if you're, a 25-year-old in a car accident and you're expected to make a recovery, but it might be like a 12-month recovery at an inpatient rehab facility, that would be a reason to consider the long-term feeding tube. And I'm discounting a whole host of particularly neurodegenerative disorders. So thinking about things like ALS, particularly, where a feeding tube discussion is very different. And so I just want to name that and honor that. And certainly think that conversation is a much more important piece in that setting. So I just wanted to call that out. But for the average person that's filling out their MOST form, the decision about whether or not to pursue a feeding tube, and then particularly long-term versus short-term, again, generally, if you're someone who's filling out a POLST because you're seriously ill and or very frail, I would try to stay on the edge. I would avoid the long-term feeding tube because I don't think you're going to get the benefit that we're hoping for. I also have plenty of patients that say, look, if I can't feed myself by mouth and maintain my own nutrition, I'm at this phase of my life, do not put a feeding tube in me, which is also completely reasonable. I think a whole other talk could be on the complications of artificial nutrition, particularly at the end of life. So I think that's a very reasonable approach as well. But for all of these options, we always provide comfort feeding, meaning that if the individual is showing signs or telling us they want to eat, then of course we allow them to eat. We do that in somebody that has some sort of swallow dysfunction, with the allowance that, hey, it's likely that because of that swallow dysfunction, you may end up with something like a pneumonia. We call that aspiration pneumonia, where people are not able to actually get their food or their saliva or anything that's in their mouth into the right tube. So sometimes it can actually go into our lungs and cause that infection, which leads me to the topic about antibiotics, because when we do have a risk for something like aspiration pneumonia, and that's again, that swallow dysfunction that impairs our ability to safely swallow and avoid things that shouldn't be in our airway, then the only real treatment for aspiration pneumonia is specifically IV or IM antibiotics versus oral. So the antibiotics that we take by mouth are not able to treat the aspiration pneumonia. So I always will have a conversation about antibiotics in the setting of feeding tubes, because for that reason. I also talk with folks depending on what their goals are. For many people who say, look, I've had this long-term illness, or I no longer have quality of life, I don't really want to extend my suffering. Please, if I actually get an infection, just don't treat it and allow me to die of that infection. And so I think that's also, it can be a very reasonable approach. When people choose not to pursue any type of antibiotic and we expect their body to actually die of an infection, then I always reassure folks that we will still, of course, optimize all symptom management so that someone with maybe a pneumonia that they've decided, I should say, not to treat, we are still going to be able to manage your shortness of breath or cough or struggle to breathe, because we do not want you to experience bad symptoms because of this infection. Instead, we want to optimize your symptom management. So part C and D, I told you we skipped over that. Those are just telling us who was in the discussion and the signatures of those folks. So we've kind of been over that. So I want to go through another scenario. So this is a bit different. So the first one was an otherwise healthy person in their 50s who experienced a car accident. In this next scenario, we're going to look at somebody who is frail and 78, who has advanced stages of heart failure. So this person is at home, they're by themselves. They're starting to really struggle breathing, which can be really common in heart failure exacerbations. This person is, they've had heart failure for years, and they've had exacerbations before. So they're starting to feel it. They know what's coming on. And so they're pretty attuned with their body. They call 911. Unfortunately, when EMS arrives, they're out. They're passed out on the floor because they were struggling to breathe so much. They're just out. EMS looks on the refrigerator and is able to actually review the POLST form that the person has already completed and placed where EMS are trained to look for it. So the EMS folks actually review the POLST. On the POLST, you'll have the healthcare agent listed. EMS calls the healthcare agent and then actually transports to the hospital for selective treatment. And that's all aligned with the individual's POLST form. Whoops, pardon me. So I want to just really be clear that with the POLST, even if you don't have a loved one there, as long as your POLST is actually in a place where EMS is trained to look, very most often, I mean, that is one of the most important things that they're going to do, is they're going to look for the POLST form because they want to provide the care and aligned with your wishes. So going through the two scenarios of someone with an advanced directive versus someone with a POLST, we know that there's been a medical emergency of some kind, we dial 911. So if someone does not have a POLST, we're wondering, do they have a healthcare directive? So yes, they do. So again, as we learned before in our previous scenario, they have a healthcare directive. We are able to identify who the agent is, and the agent is able to make decisions for the person as directed or as guided in their directive or in their living will. If they don't have a healthcare directive or can't be located, then the next of kin is the default, and the mode of care is, quote, do everything, until we can actually identify what these person's goals would be. Versus if you have a POLST, the EMS, the first responders, are really going to be able to provide the care that's aligned with you, with what you want.
Susan, I'm going to jump in and just ask a question that is relevant here. Someone asked, why shouldn't everybody have a POLST at any age?
So I love that question because I think I am an outlier in the medical community. I actually kind of believe everyone should have a POLST personally, especially because, again, I think all of us have a right to have our voices heard and our wishes honored. And the POLST, again, I say this over and over again, is the only way to actually be able to do that. If there's a time where you can't, the POLST is our main safeguard to allow that to happen. Speak for us, I mean, when we can't speak for ourselves, and have the medical community actually honor our wishes because it's direct order. So I think in my little patient advocacy heart, which is big, I hope, I really think all of us should have a POLST. I personally have one. I do think everyone should have one. I will say all of the literature and all of the organizations that support and educate about POLST forms and MOST, et cetera, all speak to it needing to be, that people who need a POLST are those who are seriously ill or frail, or that timeline I gave you where a physician probably thinks you may die within the next 12 to 24 months. And I think the reason for that, and I'm talking with with colleagues, I think a reason why they kind of narrow it to that specific group is really trying to focus and harness the people that really, really need it. Whereas generally, most people aren't really thinking about their end of life wishes throughout life until they get to a certain point. So I think they're just trying to focus their efforts into like the core group that really is going to benefit from it. But I do appreciate that question, and I don't think I really answered it well, but I just wanted to validate the question, first of all, and to say that I don't think it's a terrible idea for all of us to have this. And again, emphasizing, especially if any of us, regardless of our medical state, if you have strong wishes about the care you would or would not want, do a POLST and tell people.
So I'm going to jump in and just say, I kind of disagree.
That's fair. Yeah, see,
I don't have a POLST,
Uh-huh.
and I feel like there's too many unknowns for me to know what the medical directive should be, because I'm basically healthy. I think people who have an illness and have some predictability about what could potentially happen, and therefore they can anticipate what they might want, that's where a POLST is most effective. But for me, I don't know what's going to happen to me. So it's hard for me to make an order for something, with no basis. So that's why I would say,
yeah,
you probably don't need a POLST, but
difference
of opinion.
That's actually that is the much more commonly held opinion. So I wanted to be a deviant there for a second, share my own thoughts. But yeah, I think you're right, Rebecca. I think that is kind of the definitely more common perspective. But the POLST doesn't mean anything, and no amount of you meaning any of us deliberating our POLST or end of life wishes means anything if the people that need to hear it and see it don't. So you've got to make sure your voice is heard. You want to make sure that your loved ones and your caregivers all, number one, know your wishes. I always encourage people to actually ideally bring everyone together and ideally record it or videotape it, something, so that when there's some sort of tragic situation or drama and family and medical emergency, people aren't saying, no, but she said this to me, but no, but she told me that, and I thought she said this that one time. If you have your voice recorded, telling the people who are going to be a part of your care team what you want and what you don't want, if they hear it from you in your voice, that's going to be such a gift to them. And it may feel morbid. I want to honor that and name that too, that it could feel really morbid to say this, but I've had so many patients tell me what a relief it was to actually make that recording, to actually share their information with their loved ones, as if a weight were just lifted, because they were clear. And then once the conversations were had, and for many of the patients I've worked with, it's been really hard for them to initiate the conversations with their loved ones, because interestingly, oftentimes it's the younger loved ones that don't want to talk about it and don't want to hear it. And so they tend to avoid it. But I do think that the more you can talk with your caregivers, with your loved ones about what your wishes are, the more likely your wishes will be honored, first and foremost. And the less, I think, discord or distress they might have in those really stressful and urgent times of an emergency situation. So yes, tell everybody and tell them where you keep your documents. Give everybody copies. You know, in our electronic or digital age, you know, email copies, send pictures of copies. Always give everybody copies, because again, you saying this is what she wants or doesn't want doesn't mean anything until the emergency medicine folks can actually see a copy of it, whether it's a physical copy, a hard copy, or it's actually a digital copy on your phone. You also want to make sure that all of your healthcare providers, because a lot of folks out there have a lot of different doctors. And unfortunately, if you're not in like an organized system of medicine, you may have multiple different doctors across town. And as much as we wish they were, they're not communicating. And their EHRs or their electronic health records may not be communicating. So just because one doctor has it doesn't mean the other doctor has it. Or just because one hospital within one system has it doesn't mean the other hospital in the same system has it. So you really do want to make sure that everywhere you go, you are saying, and here's this, and here's this, and here's this. I can't stress that enough. The other thing is, in your home, emergency medicine folks are actually trained to look. The two places I've always been taught are behind the refrigerator, on the refrigerator, pardon me, and the back of your front door. And so when your emergency responders first come into your home, those are the places they're going to look to see if there's the POLST form specifically. And then the other thing now, and again, digital age, I have lots of patients that will take pictures of their documents and send it to their loved ones via the camera or via their smartphone. There's also a way on your ICE, or in case of emergency contact, if you have an in case of emergency contact in your phone, then you could also in that just say see photos for documentation, or just indicate that, because emergency medicine folks are also trained to be able to access the ICE, the in case of emergency contact card. And I think in certain iPhones and certain models of iPhones, there's the medical card that first responders are actually able to access in an emergency. And so that will come up with your medical information, like your medications and allergies, et cetera. And you can actually put on there that you have completed the POLST form, and please see the photos for additional documentation. The tried and true method that I think is never going to go out of style, and I hope it doesn't, in the digital age, is your actual wallet. Being able to hold a copy of, everybody's always gonna be looking for your insurance card. They're gonna want to get payment. They're going to check your wallet. In next to your insurance card, you can type in I have, or you can fill out a card that says, I have completed a POLST form. I've completed a healthcare directive. This is my healthcare agent. This is their phone number. These are my wishes. See POLST. You just want to do everything you can to really make sure that your voice is heard. The most important thing, I should say the most important, I think equally important, talk, share, tell everybody, do it again and again and again. Knowing that there's going to be folks that really are going to resist it, and there's going to be folks that are going to maybe have different opinions than and maybe not agree with the care you've chosen for yourself, but know that it is your right. And all of us throughout our lives, our healthcare decisions are going to change, and that's normal, and that's okay. But you want to talk, you want to share, you want to tell people, tell your loved ones, tell your caregivers what you want and don't want. Yes, there we go. Inform, tell everybody, and then connect these people. So for a lot of people that maybe have, a lot of people, a lot of us have challenging families. And so maybe people aren't communicating well, and that's their normal. And then some sort of medical emergency happens, or there's an end of life situation, and the stress of those situations don't get any better. And so if you in your healthier stages can actually go ahead and connect these people to say, here, this is this person's name, these are their phone numbers, here are my providers, here are their phone numbers, that's going to actually lessen just a bit some burden when people are facing those really stressful times. Rebecca.
Yeah, I'm going to just mention a few more things. So I always have to give a few caveats because, a POLST is your absolute best bet. However, religious affiliated EMSs may not follow your POLST. So those of you in Duluth, you might want to find out which EMS system has a contract with your county, because if it is a religious affiliated EMS, they might not follow your POLST wishes. I wish we could tell you who they all were, but we can't. Also, many long-term care facilities must dial 911. They must. So it's really important that you have a pulse there available so that when the EMS comes, there it is. They can locate your pulse. Because even if you say, don't call 911, I'm ready to go, I've got my morphine, they're going to do it. So just to know that. Next slide. I'm going to skip. Oh, and I just like to hammer this home. And now I'm talking about advanced directives, not POLSTs. But people say, why aren't my advanced directives followed? I have an advanced directive that says what I want. Well, number one, family disagreements. So an advanced directive really just names your agent. It's not decisions that you make for the future. It's information you give your decision maker who will be making those decisions for you. That's different from a POLST, which is an order, it's a decision. An advanced directive is not a decision, it's appointing a person. That's the decision. So if family members show up, the person who's there is often going to sway all the decisions. So it's really important that your agent is accessible. Put their, like Susan said, get a card, write your agent's phone number, put it with your Medicare card. They have to be accessible. They have to know what you want. They have to be willing to stand up for you. The other reason healthcare agents aren't followed is they're inaccessible. Nobody knows who they are, how to reach them. The document isn't even at hand. And the other problem is that they can be too specific. So that's why, while a POLST is very specific, an advanced directive shouldn't be so specific as to constrain your decision maker, because you don't know what the situation is going to be or what decisions will need to be made. So next slide, I'm going to hold questions for the end because some of them are related to the next section. So next slide. So I don't know if anybody has heard of a POLST registry, but there is such a thing, which is a digital repository that houses POLST forms to make them available to healthcare professionals when they're needed across settings. Oregon has a wonderful system they've had in place for years. So the EMS can literally go online while they're headed to your house, pull up your POLST, and know what to do before they get there. 5 states have a POLST repository. Surprise, surprise. Oregon was first, but then Idaho, Louisiana, New York, and West Virginia. Who knew? Who could predict? 20 states are in process, including Minnesota, which, by the way, so we first had our POLST just suggesting a POLST system in 2008, and then a document was created in 2010, which has recently been updated. And so the next effort is to try to get a POLST registry here in Minnesota so that all those POLST forms can be available. And in fact, last legislative session, last year, the legislature passed a study of a POLST, and you can find it online. Go to the health.state.mn.us and just put POLST in the search. There's a whole study they did, the Department of Health. What do they need to do a POLST registry? How much will it cost? Details, details. And it did not pass this session. So this is something that's coming up again in the legislature to be aware of, because a POLST registry would really help a lot of folks. Next slide. And then I just wanted to put these specific Minnesota Advanced Directive document and the Minnesota POLST document where you can get those. People are writing. And then we also, yeah, go ahead and leave that up. So Compassion and Choices also has a lot of tools to help you with your end of life planning. You still need these specific documents, but in the planning process. So next slide, you can go to our website and find resources. So if you go to the website, just look under resources, tools to finish strong. And we have not only an end of life decision guide, which helps you, but we also have a specific dementia value and priority toolkit, which helps you think about, as a dementia progresses, what level of care do I need? And so next slide. Must always say, we survive on contributions from people like you. In fact, 95% of our money comes from donors. And so if you find this valuable, I encourage you to go on to our website on Donate and make a contribution of any amount, just to keep our organization healthy and moving forward. Okay, I think you can stop sharing, Susan. And there are a few more questions that popped up. So we'll do a few moments of Q&A. And one of them, this is kind of a quiz, but so one person asked, does a POLST replace a 5 wishes document? And so I'm going to say no. And I'm going to let Susan say why.
Yay, great. I love the tag team. So that's a great question. And I get that question all the time. The 5 wishes is going to be aligned with the advanced directive or the living will. So those are all going to be the idea of offering information to serve as a guide so that your healthcare agent can make an informed decision on your behalf about your care. So 5 wishes, living will, healthcare directive, those are all guides and information to help people make decisions for you, versus the POLST is going to be that medical order. It's not a guide, it's a direct order outlining the wishes you have already decided for yourself.
So I am going to, we don't have, we've answered most of the questions. So I'm going to do a pop quiz, which is you never lose, you only learn. I wish I was more tech savvy and I would do one of those nice surveys online where you can punch the buttons, but we didn't have time for that. So here, true or false, just answer it for yourself. I could go to the POLST website, download a POLST form, fill it out, and put it on my refrigerator, and it will be honored. False. It must be signed by your doctor, nurse practitioner, or PA. So you must have the conversation with your health provider. And that is the person, once they sign it, it becomes official. Before that, it doesn't.
Can I say?
Oh, go ahead. Yeah.
Oh, sorry. I was just thinking about this because I've seen this a fair amount, unfortunately. Most facilities require when someone is admitted to their facility, it could just be like a short-term rehab stay. Maybe you're in the hospital for a little bit and they just want you to go for just a little bit, get a little stronger, then head home. But most facilities are going to require their patients to have POLST forms completed upon admission. So oftentimes what I've seen from patients is, you know, they're being transferred from the hospital to the facility and they're given this packet with lots of things, tons of paperwork, of course. And one of those forms is a POLST form that they're just given. And then they're kind of told or asked to fill it out, or families asked to fill it out kind of casually by the, you know, administration person that's doing their intake. And then whoever is the provider that's servicing that facility at the end of the day or whatever, one time a week, whenever they come, they just have a stack of POLST forms. They just sign. And I say this because I have seen countless POLST forms, and most in Colorado, filled out that are completely incongruent and make no sense. Like it'll say, yes, CPR, comfort measures only. And things like that. So make sure that if you or a loved one are ever in a facility, because it can often happen when you're in that transport state, not really totally with it. Most of us aren't in that state. If that ever happens, make sure that if somehow you or a loved one have a POLST form, that you recall the conversation and or the person who's it's representing has had the conversation with the provider to make sure that it really was intentionally and deliberately completed. That's all.
So a couple more quick true false questions to solidify your learning. True or false, if I have an advance directive, I can be assured that my wishes are going to be followed in my advance directive. The answer is no, you cannot be assured of that. What you can be assured of is if your advance directive is available, that your healthcare agent is available, they will be empowered to make decisions for you. But an advance directive is not a standalone document. A human being, the individual who's there, is going to be the one who makes the decision for you. I just want to say I see a whole bunch of people coming into this presentation, and I am sorry if the reminder said 5 p.m. It probably said 5 p.m. Eastern. I don't know, but this was at 4 p.m. Central, and good luck. I've recorded it. So we have this recording, and I will send this out to folks. And I really apologize for that confusion. But yeah, this was 4 p.m. Central, 5 p.m. Eastern. So sorry about that. Any other, we have like 1 minute left. Does anybody want to ask a very quick question to help reinforce our learnings and or get a burning question answered? If you do, come off mute and do it.
I have a quick question if you can hear me. It's Wendy Brown.
Yeah, go Wendy.
I'm curious, for those situations where 911 is called and someone has basically marked on their pulse that they only want comfort, I think that's confusing to people because, and so often you call 911 and they're there to save lives. So could you give examples of the kind of comfort that EMT provides if they did mark basically that they just want comfort focused treatment?
Yes, thank you, Wendy. I actually, in my own practice, advise people not to choose comfort unless they are enrolled in hospice, because really hospice enrollment, your hospice care team is really going to be the only way that we have in our, honestly, in our kind of medical infrastructure to be able to provide true comfort focused care. And I say that because emergency medicine responders or EMS folks are not able to do true comfort care without the direction of the medical provider. So they can do, like, if someone is obviously in respiratory distress, they're at the end of their life, they're clearly actively dying and they're having significant breathlessness is a common example I would hear. The EMS folks would then have to call whoever their medical director is. So typically, and this is someone who's not enrolled in hospice, so they'd have to call their medical director, usually an emergency medicine physician, to talk through the case, who would then allow them to dispense or push morphine or Ativan or something like that to help with the person's breathing if we know the person's truly actively dying. But that so rarely actually happens, that there's such concern or distress that we're not treating the person, that the person gets brought into the emergency room. So that's why, for me, I think that choosing comfort focused care really is best protected and served when someone is already and or very soon anticipating being enrolled in hospice, because they become your 911. I don't know if that answers the question. I think that the other benefit of comfort focused care for someone who is not enrolled in hospice is that while the EMS folks aren't really able to provide that real true comfort focused care, it at least messages to the broader care team, hey, this person really does not want life extending care. We need to expedite a hospice referral. Another thing that can happen, and this used to happen in our hospice, and I mean still does, but where we can actually expedite a hospice admission as a result of EMS responding to someone in their home. They're clearly actively in distress. They need more aggressive symptom management. They want comfort only focused care. So then we can, through coordination, again having to go through the EMS medical director, the physician, coordinating that with the hospice medical director, we can try to get that person enrolled in hospice immediately. That doesn't happen very fluidly most often. Which is why generally, if somebody does want comfort focused care but is not enrolled in hospice and or is not eligible for hospice, then my encouragement would be for them to consider, quote, selective treatment, but then to really articulate on the form where you can write additional orders that patient prefers to avoid life-sustaining care, do not prolong suffering. If meaningful recovery is not anticipated, please transition to comfort and enroll in hospice. But I actually will physically write that out to make sure that it is seen as a physician order in the setting that the person's not enrolled in hospice yet.
Well, I see we're a couple minutes over, so we're going to have to stop there. Thank you so much, Susan. You're a wealth of knowledge. You've really made this complicated thing, I think, understandable. Again, to those of you who joined in the last 5 minutes, I really apologize that you got a wrong message. This started at 4 p.m. It may have said 5 p.m. Eastern, I don't know, but we've recorded it. And so the recording will be available to everybody. Again, I apologize for that. And thanks everyone for being here. And thanks for all you do with Compassionate Choices. Take care.
Thank you all so much.